Professor of Medicine, KIMS, come and occupy the chair as the chairperson.
Is it working?
Yeah.
I'll just close it.
Yeah.
Thank you very much for all of you. Happy New Year and thanks for coming for the CME today. My topic is update on hypertension and what are the current guidelines. Feel free to ask me any questions while we're going through this thing. I don't have any disclosures, and the objectives are pretty simple today. A brief review of the previous studies and guidelines, and also understand the current guidelines and where do we stand today and how did we get there. For example, if you start with the history of the blood pressure trials, you have to start in 1967. VA has done a study, the Veterans Administration in the United States has done a study that was looking at this question: is severe hypertension, which they have defined as 115 to 129 diastolic, is it treatable? So that was the question in 1967. And when they asked that question, their answer was yes. If you treat it, people will have fewer strokes and less CHF. So obviously, it made sense to start treating severely hypertensive patients there. 3 years later, the same question was asked, but instead of looking at the severe hypertension, they were asking in moderate hypertension, which was defined as 90 to 115 diastolic pressures. Once again, it was a successful study, and it said, yes, you treat this, and people will have fewer strokes and less CHF. So there's no doubt about treating moderate hypertension any longer. In 1979, the hypertension detection and follow-up program has started, and their goal was, if we treat the blood pressure to a specific goal, are we going to get any better results or not? And they have done, if you target the blood pressure to diastolic of 90, you get 36% more reduction in the strokes in those patients. So all these studies have been really successful, and these are the steps that the medical societies have taken, medical profession has taken to make us come to better and better control of the blood pressures there. These are the steps that people have taken already, and we are ahead of this. In 1986, the European Working Party on high blood pressure in the elderly program, they were asking, is it really worth treating hypertension in old people? And they define old people as anybody who is more than 60 years old in 1986. So, and their study was also positive. Even though these are 60 years and older, you can reduce their mortality by 26%. That's a huge improvement. And also decrease cardiovascular mortality by 43%. So that's a good improvement in older people that they were calling that. Subsequently, in the systolic hypertension in the elderly program in 1991, they were asking the same question: is really treating systolic blood pressure, is any worth it? Until that time, we were focusing on diastolic blood pressures. And now we are looking at, is it really worth treating the systolic hypertension? And this study said treating systolic hypertension of more than 160 prevented strokes by 3%. Absolute risk reduction was 3%, a huge improvement there. And also decreased myocardial infarction as well as all-cause cardiovascular death there. The hypertension optimal treatment study in 1998 was asking this question: lowering the diastolic blood pressure to 85, maybe 80, is it beneficial compared to the standard 90? Because we already decided that 90 was good enough for the diastolic pressure. So they were asking, how about if we lower it to 80 to 85? Is it any better? And this study is a negative study. They didn't really come up with any positives, excepting for a small benefit among diabetics. So diastolic pressure of 90 is where we were stuck there for a while. The hypertension in the very elderly trial, 20 years later, the elderly were defined as people who are 80 years and older. So 20 years earlier, 60 years old is old enough for you, but now we got 80-year-old people. And is it really worth treating hypertension in an 80-year-old person when they have systolic blood pressure more than 160? And their answer was, yes, it is still worth it, even though they're 80. There are 30% fewer strokes, 64% less CHF, and 21% fewer deaths there. So really no reason not to treat an 80-plus-year-old person who has hypertension, which they define as more than 160 systolic there. The action to control cardiovascular risk in diabetes study in 2010, they were focusing only on diabetics, and their goal for blood pressure was less than 120. Their question was, is less than 120 systolic better than the 140 that we were focusing on earlier? And this is a negative study also, no significant difference in mortality, cardiovascular events, or even renal protection. Everybody was expecting in a diabetic, if you titrate the blood pressure to 120s, you're going to have a renal protection there. But they didn't find any at all. So that was kind of a disappointment. And then in 2015, the systolic blood pressure intervention trial came, and these were pretty much the same as ACCORD, excepting that these are non-diabetics. You're asking the same question, but in non-diabetics. This study showed that there is a 27% improved all-cause mortality and 25% improvement in the primary cardiovascular outcomes. So this is the reason new guidelines have come, and they were pushing for lower blood pressure goals there. In 2014, the JNC8 guidelines came, and they were talking about, this is a busy slide, but I'll try to make you focus up here, that really these are the guidelines to see how low do you want to do it. This was before the sprint trial came, and so their target was 140 or 90 or less than that, excepting for the people who are more than 60 years of age, where they gave a target of less than 150 or 90 systolic there. 150 systolic and 90 diastolic there. So everybody else gets the same number, excepting for people who are more than 60 years of age. And here are a couple of things that I want to focus on. The initial drug of choice for hypertension management in 2014 when JNC8 came, ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, and calcium channel blockers. There's no beta blocker there. And even today, beta blockers are not used as a primary therapy for any hypertensive patients, excepting for people who have stable ischemic heart disease or congestive heart failure. So those are the two groups of patients who get beta blockers, but everybody else gets these medications. And these medications are all pretty equally good. There is no preference for one over the other, excepting in some categories that we will touch later on. The strategies that we were asking about in one of the questions, strategy A is you start one drug, maximize it before you add a second drug. And the strategy B, which I like, is you start one drug and you add a second drug before you maximize the first drug. And strategy C is if a person has more than 20 systolic above the target or 10 above the target diastolic pressure, you can start two drugs at the same time. It could be a combination therapy. In India, we have a lot of combination pills, unlike in the US. But even in the US, they are allowing combination medications nowadays. So you could start that way too. And we're not really focusing too much on it, but all of the guidelines will tell you, you have to have lifestyle changes. And the lifestyle changes include if you're a smoker, not smoking, if you're obese, losing a few pounds, and if you drink alcohol, not drinking more than 2 if you're a man, and if you are a woman, not drinking more than 1 alcohol drink on any given day. Those are the things that you need to do. And physical activity, at least about 3 to 4 times a day is all we need to, 3 to 4 times, say a week, is all you need to exercise for 30 minutes or more. So those are the things that we need to do. Lifestyle changes are part of every stage of antihypertensive therapy. There are no exceptions to that lifestyle change. We may not be focusing too much on it because we are interested in learning all the new drugs and new things, but lifestyle changes have been there since 1960s or even earlier, and we need to stick to that. The new guidelines came in November of 2017, and these guidelines have been updated in May of 2018. In prior guidelines, there was insufficient evidence to demonstrate any benefit for blood pressure goals of less than 140 or 90. But as we said, in 2015, the SPRINT trial came, and that has shown that we really should lower the blood pressures even more than the 140 or 90. That's the reason for these new guidelines there. And I just want you to look at this. I'm going to spend a few minutes on this. The normal blood pressure, according to American College of Cardiology and American Heart Association, should be less than 120 over 80. It's not 120 over 80. It should be less than 120 systolic, less than 80 diastolic. And elevated blood pressure is defined today as 120 to 129 systolic and less than 80 diastolic. Stage 1 hypertension, 130 to 139 systolic over 80 to 89 diastolic. And I want you to look at this. Stage 2 hypertension is 140 systolic, but look at this. 90 or less than 90 diastolic, you get stage 2 hypertension. So also, individuals with systolic and diastolic blood pressure in 2 categories should be designated to the higher blood pressure category. So if you see a person who has 120 over 90 blood pressure, they are in stage 2 hypertension, 120 over 90. So that is a big shift in our thinking, and the paradigm shift is what I would call that. That led to this epidemic of everybody getting classified as hypertensive. If you use the current guidelines, 46% of the American population is hypertensive. And if you use the older guidelines, only about a third of the Americans would qualify as hypertensives there. So we are making more hypertensives by changing our definition. What about India? The India story is not that far behind America. You know, we are catching up with America on all aspects, including our ill health. 40% of the urban population is hypertensive. And the rural population, they're happily still living in a healthy environment. They're probably more active, and only 12 to 17% of them are hypertensive there. Between men and women, there's not a huge difference, and global averages are also pretty similar to that. These are a few maps. The top one is for diabetes, and the bottom ones are for the hypertension. These are relatively new maps. You can see Telangana is actually a separate state there, so it's less than 4 years old. So you can see that the southern states are more diabetic, and hypertension, also we are pretty similar that southern states have more hypertensive too. You can see Kerala has got a pretty dark map there, and Himachal Pradesh and Punjab, they're also pretty dark up there, about 4 or 5 years ago. This is a paper that was published in 2014, Journal of Hypertension, and what they found is around 25% in the urban and 10% in rural population are hypertensive there, the same as what we said. The World Health Organization estimates that nearly a third of the Indian people would be hypertensive or at least elevated blood pressures. Andhra Pradesh at 13.3%, Odisha 9%, Chhattisgarh and Gujarat were the highest prevalent states for hypertension. And there in this study in 2014, Kerala only had 2.4% hypertension there. But I was reading Times of India a few months ago, in October, and this headline caught my attention. Hypertension capital of India, Andhra Pradesh, men, urban men, 36%, number 2 in the country. And even more surprising to me was, look at it, Kerala becomes #1 for men, hypertension-wise. So I'm not really sure what is going on in Kerala, what they are eating, but it is a concern there. But even more concerning, in the bottom part here, you look at how prevalent obesity is. 43% of the urban women are obese in India. So we're going to go to the guidelines there. According to the guidelines, the blood pressures that you really need to use to make a diagnosis should be done out of the office, not when the patient comes to see you in the clinic. That's not the blood pressure measurement. So out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension, and even for further titration. You don't want to use their office blood pressure to utilize that. And the non-pharmacological interventions, I'm going to quickly go over them. I want to tell you the level of evidence for all of them is A, #1, the highest category there. And the category of class of recommendation is also class 1. Weight loss, a heart-healthy diet such as DASH diet, which is the dietary approaches to stop hypertension, sodium reduction, as well as potassium supplementation, excepting in patients who have chronic kidney disease or who are taking any ACE inhibitors, etc., the potassium-sparing drugs there. Continuing with the non-pharmacological interventions, increase physical activity, not a lot, just walk 30-40 minutes a day, 3 to 4 times a week is all they are recommending. Adult men and women who drink alcohol should not drink more than 2 for a man and 1 for a woman on any given day. And the blood tests that are being recommended or other tests that are being recommended are pretty standard, like fasting blood glucose, lipid panel, complete blood count, echocardiogram, EKG, etc. These are not anything unusual there, so nothing new to learn there. Going to treatment of the hypertension, even though this slide is pretty busy, we're going to analyze it pretty quickly. If a person has blood pressure of less than 120 or 80, we're going to call it normal. So easy. We really don't have to do anything. Ask him or her to come back a year later, tell them not to smoke, tell them not to gain weight, and be physically active there. If the blood pressure is elevated at 120 to 129 or 80 or less, you start with non-pharmacological therapy, pretty much what you told these guys, and reassess sooner, 3 to 6 months rather than waiting a year there. Stage 1 hypertension, the target is, again, if they have any coronary artery disease, let us say he already had an MI, you want to treat them more aggressively, or if they have 10-year risk for cardiovascular disease is more than 10%, you want to use non-pharmacological therapy as well as blood pressure lowering medications there. If they have no CAD and no significantly elevated risk, then you can do non-pharmacological therapy alone for them. And finally, stage 2 hypertension, you are going to continue with the non-pharmacological therapy as well as blood pressure lowering medication. So really not a complex slide. Continuing this, if the patient has blood pressure goal that's met, you'll reassess them in 3 to 6 months. If not, you call them back in a month so that you could titrate their medications up and call them back again until you get their blood pressure under good control. In the previous guidelines, ACC-AHA recommended combining ACE inhibitor and ARB together, but today they say it is harmful. You should not use those 2 combinations at all. So that's a major change there. And what about patients that have stable ischemic heart disease? The target is less than 130 or 80. It's always 130 or 80 for all of these patients, and that is one of the questions that we ask there. For the systolic blood pressure, there are randomized trials. For the diastolic blood pressure, there are no randomized trials, but expert opinion says that you should get it to 80 or less than 80 diastolic. So whenever you have stable ischemic heart disease and high blood pressure, you got to use them guideline-directed medical therapy with beta blockers, ACE inhibitors, or ARBs. Because of their ischemic heart disease, beta blockers are first line. And if they had previous MI, stable angina, you could use other drugs as a second line, like dihydropyridine calcium channel blockers, like amlodipine or nifedipine. And you can also use thiazide diuretics as well as the spironolactone and other mineralocorticoid receptor blockers there. Continuing the ischemic heart disease management, you could always add the amlodipine or other dihydropyridine calcium channel blockers. These are non-randomized trials, but the recommendation is actually class 1. Class of recommendation is number 1 there. In adults who have had MI or acute coronary syndrome, you can continue the medication, the beta blockers, for more than 3 years. That's a class 2A recommendation. Those are non-randomized trials, but still, this is acceptable. And this is also expert opinion, also says that patient may be considered to control hypertension. You can control the calcium channel blockers in patients with CAD as well as heart failure with reduced ejection fraction. Okay? You can continue it for 3 years or longer. Once again, if the patient continues to have angina and has non-coronary artery disease and hypertension, you could add dihydropyridine calcium channel blockers. This is kind of reiterating what we have already talked about. Heart failure patients, in adults with, their target is also less than 130 or 80. And for systolic blood pressure, randomized trials are there, but for diastolic blood pressure, expert opinion, not any randomized trials there. Recommended treatment for hypertension should be less than 130 or 80, and the non-dihydropyridine calcium channel blockers are not recommended in the treatment of hypertension in adults with heart failure with a reduced ejection fraction. Non-dihydropyridines are the diltiazem as well as the verapamil kind of medications. You don't want to use them in reduced ejection fraction patients there. What about patients with preserved ejection fraction? One of the first things you want to do is, if they have volume overload, you want to start with diuretics on them. You want to get rid of the excess fluids. And then you can add the usual antihypertensive medication like ACE inhibitors, ARBs, and beta blockers to get to a 130 or less than 130. Chronic kidney disease is pretty common among hypertensive patients. And here it talks about this, the medications are pretty much the same even in chronic kidney disease. But if they have albuminuria, which is defined as more than 300 milligrams per day, or more than 300 milligrams per gram of creatinine, you can use ACE inhibitors. This color tells you is a class 2A. And if the patient is ACE inhibitor intolerant, you could use an ARB. So you can start with an ACE inhibitor. Otherwise, if they don't have albuminuria, even if they have chronic kidney disease, first-line medications like diuretic, ACE inhibitors, ARBs, calcium channel blockers, you could use all of them. And here in patients with acute intracerebral hemorrhage, if their blood pressure is between 150 to 220 systolic, lowering the systolic blood pressure to less than 140 is harmful. You don't want to do that in intracerebral hemorrhage patients there. You want to leave them slightly higher there. And if they have high blood pressure, very high blood pressure at more than 220 millimeters, you could start them continuous IV infusion and closely monitor their blood pressure. And don't lower the blood pressure too much. And this is for the patients with acute ischemic stroke. The first thing you want to decide when you meet a patient with acute ischemic stroke is to decide whether they qualify for thrombolytic therapy. If they qualify for thrombolytic therapy, you got to lower their blood pressure to less than 185 systolic or less than 110 diastolic before you can give them thrombolytics. And you keep maintaining them around 180 or 105 for the first 24 hours after you give IV thrombolytics there. You don't want to lower them too much. But if they have, let us say they are not qualifying for thrombolysis and their blood pressure is less than 220 or 110, there is no evidence that lowering their blood pressure is going to make them less disabled or less dependent. So there is no recommendation to rush them and start them on any aggressive antihypertensive therapies. If you're not giving thrombolytic therapy, sit tight on them, unless they have very high blood pressure. Then you can lower the blood pressure around 15%. The guidelines say 15%, but if you're using pure medications, you cannot always predict how the response is going to be. So you have to be careful about it. What about a patient who has had stroke more than 3 days ago and now is neurologically you shouldn't be using ACE inhibitors, ARBs, or direct renin inhibitors because of the fetal malformation that happened with them. So that's a pretty standard. There's nothing unusual, nothing great there. What about patients undergoing surgical procedures? Every day, millions of people are having surgical procedures done, and a lot of them have hypertension, and we need to be on top of their management there. Patients that are going out of having this and are already on beta blockers should be continued. You should not stop them. At the same time, if the patient is having elective major surgery, whatever hypertension therapy they are on, to continue with it. Here, in patients with hypertension, the ACE inhibitors and ARBs, you could potentially stop them perioperatively, preoperatively, mainly in case the patient experiences any kind of hypotension episode. You could potentially protect their kidneys by stopping these drugs, but not the beta blockers. You don't want to stop the beta blockers there. If the patient has high blood pressure, more than 180 systolic or more than 110 diastolic, you can defer the surgery. And I think a lot of times anesthesiologists run into that problem, and they would like to put it off for another day, which is a reasonable thing. But for patients undergoing surgery, about abrupt preoperative discontinuation of beta blockers is class 3 recommendations, harmful. You do not want to stop it. Not the beta blockers, not the clonidine either, because of the rebound hypertension and rebound tachycardia that they experience, and it could be dangerous. Because we love beta blockers so much, if you run into a patient that has not been on any antihypertensive therapies and they are going for surgery in an hour, and you say, hey, you know, I like my metoprolol so much, let me put him on this, they say it's class 3. You don't want to potentially become extremely bradycardic around the anesthesia induction, or they could become extremely hypotensive too. So you want to be careful if they have never been on beta blocker. But if they have been on beta blocker, you could. What about intraoperative procedure? Nothing big here. It's also expert opinion. They said if you need antihypertensive therapy, use intravenous medications. Sure, we'll use that. Nothing else. You can't give them pure medicines anyways. How about what are the strategies that we could use in office to improve our patients' adherence to medications and how to get their blood pressures under better control? If you can give them once a day medication, they're probably going to take it more regularly. If you say you're going to take it 3 times a day, the chance of him or her missing it several times a week is going to be higher. Use of combination pills rather than 3 individual components can be useful to improve the adherence to antihypertensive therapies. That's also a good idea, but in reality, I don't see a lot of combination medications available for us in the USA. Maybe these guidelines are going to change them. I don't know. We'll see. Once again, effective behavioral and motivational strategies are always going to be recommended. People listen to you. If they decide to follow them, they probably won't be hypertensive to start with. And know your numbers. Normal is 120 over 80. Elevated is 120 to 129. Systolic over 80. And stage 1, 130 to 139 systolic, 80 to 89 diastolic. And stage 2 is 140 and about 90 diastolic. 90 diastolic is what I really wanted to emphasize. And I want you to know that if you have a person with 120 systolic and 90 diastolic, they are in stage 2 hypertension there. So that's really the big thing that I want to emphasize there. These are some headlines that really came over the last several months. Some of them are not surprising. For example, spikes in violent crime linked to increased blood pressure. If you're living in a neighborhood that has got a lot of violence, and this is a Chicago story, your blood pressure will go up unless you're oblivious that something is going on out there. And what about this thing? Big evening meals increase risk for prediabetes and high blood pressure. So a lot of people are busy during daytime. They don't eat breakfast. They're at work, and they eat very little lunch. They come home, and and they have a huge dinner. And that's what is probably driving a lot of obesity and hypertension epidemic in our lives. And this headline, South Asians face increased risk for heart disease. I think none of us are shocked to find that out. We all know, for whatever reasons. They don't go into the reasons, they just go into the statistics there. And this is an interesting thing for me. Study confirms the link between gum disease and high blood pressure. So again, they don't go into why gum disease affects hypertension, causes hypertension, but maybe they don't take care of themselves. They don't take care of their mouth, they don't take care of their body, they gain weight, they are diabetic. So insulin resistance can potentially drive to hypertension. Okay, thank you very much for listening, and I'll take any questions if you have. Battery?
I can go to I can go to
What about BP variability, sir?
The blood pressure variability is a concern, but that's one reason why they said don't depend on the blood pressure that you check in the office. Let the patient monitor the blood pressure at home, or give them what is called ambulatory blood pressure monitoring devices. That will help in managing.
First of all, let me congratulate Dr. Prasad Kilaru for a very well presented, very informative topic. It's a good presentation. Well, the question, just a minute, sir.
Could you talk about the role of third drug? Because when the blood pressure comes down,
Yes, sir. Okay, sir.
what's the role of chlorine catapult?
Hello, please.
When do you start that drug?
You're alpha blocker, sir, which he has failed to mention, I believe, alpha blockers. Sir is asking about alpha blockers.
I basically, as a cardiologist, I never use them, but my nephrology friends keep using them, and I have to live with them. We got nice beta blockers, we got ACE inhibitors, we have calcium channel blockers. I think 90% of the time you can control the blood pressures on them. Specifically, if you can see that none of them, the alpha blockers are not listed as a first line of drugs for hypertension management there. So we have patients who have been on these medications for a long time, and I don't want to go in and stop them. I'll continue it, but I don't start anybody on clonidine. I have not started anybody on clonidine for more than a decade. My only prescriptions are for renewals.
Sir, maybe we can say that, as sir has pointed out, those patients who are resistant to the routine lines of management at the maximum dosages or in combination, maybe you can have a trial where they consider the patient regarding addition of a beta blocker or experimental drugs which are coming in.
Concerned about secondary hypertension or resistant hypertension, then you may have to work them up for that. And my topic is not on that issue today. We're just talking about primary hypertension.
Any more questions from the audience?
I think I have one question.
Sir.
Coming on the same topic. I use alpha blockers in elderly male who have prostatic hyperplasia.
Yes.
It does good job for both hypertension as well as prostatic hyperplasia. Second thing is, I use chlorine patches, especially in postmenopausal women, to reduce heart pressures and also reduce blood pressure too. Why not? Why you didn't use for 10 years? I'm shocked.
Sir, in elderly patient with prostatic hypertrophy with hypertension, we have used alpha blockers, but the problem was postal hypertension. Already elderly gentlemen having a unsteady gait and a lot of orthopedic problems. They are prone to falls. So that's why in moderation, that would be my approach.
I build.
Hypertension is probably autonomic and not hypertensive. Because naturally
No, related to alpha blockers.
Yeah, alpha blockers are notorious, and if you remember, most of the alpha blockers came as antihypertensive medications, and the cardiologists and the internists have abandoned them, only to be picked up by the urologists for prostate problems. ACC, AHA say they're not first-line drugs. If you want to use it, they're still available in the market, and I think some people still continue to use them.
Thank you. Golden rule is if it doesn't suit, then don't give it. I agree with that.
Sir?
If it doesn't suit, if it's single, then don't give it.
Yes.
There's no force there.
No, but
If it's suitable, don't stop it.
Okay, sir. I mean, the point is well taken. No, the drug suits the ultimately it's a clinical judgment. I look at so many factors, right? Age, the body's habitus, stress levels, and then I prescribe a drug. If it is suitable, good. If it doesn't suit, I'll switch over to another drug.
Also, there are so many other beautiful drugs. Why stick with a drug that has all these side effects and has no additional benefits?
The natural history of blood pressure in 100 years' time across the black people, across Hispanics and Indians, Europeans, etc. This historical blood pressure goes up every year, little by little. The diastolic pressure doesn't. The reason is systolic blood pressure is proportional to the aortic compliance, whereas diastolic to the peripheral vascular resistance. So diastolic blood pressure doesn't go up after age 50. It falls by itself. It doesn't need treatment. And then don't give treatment and say it is syncopial for that. The point I'm trying to make is treat the systolic, because it's the systolic blood pressure that is now agreed that is associated with mortality or morbidity, etc. The blood pressure measurements in the last 20, 30, 40, 50 years, the clinical trials are based on the blood pressures which have white coat hypertension. They're not really valid, you know.
Actually, hypertension, I don't believe, is a natural thing for people to have. Not all human beings develop hypertension, and especially people who have not been exposed to the Western diet. They don't, every year, don't keep having the higher blood pressure. Our diet is what is making our hypertensive, and our hypertension is what is making our aortic compliance go bad. So if you're not hypertensive to start with, and if you have followed good, healthy diet, it is not a natural for a human being to have higher and higher blood pressures every year.
Thank you for your kind words.
Thank you very much. We'll move on to the next topic. Thanks for the excellent presentation, Dr. Kilar.
Just for the audience.
So here's a memento to the speaker, Dr. Prasad Kilaruf, on behalf of the organizers.
Thank you, guys.
Okay, the next speaker is going to be Dr. Srinivas Reddy, who is a neurosurgeon in Nellore. Again, our classmate, and he's also held positions in the state level for the Neurosurgical Society or Neurology Society? Neurosurgical Society. And he has several publications to his credit. And we are excited to have him here to talk about head injuries as the traffic accidents are going higher. We are seeing more and more head injuries. So he kindly agreed to talk to us and enlighten us.
I invite Dr. Balakrishna Garu, Senior Surgeon, Kakinada, to be the chairperson.
Yeah. Diagnosis. Yeah. A very good morning, Chairperson, Dr. Balakrishna, and of course, at the outset, I express my sincere thanks to my friend, Dr. Vishnu Verma, who has given me the opportunity to stand before you this morning and interact with you. And a very good morning to all the Rangarayans. This one, yeah. So the topic which I am going to discuss today is the diagnosis management of head injuries. It's not a big message to be It's not a big message that you can get out of this topic because everybody knows this. It's only just I'm polishing the corners which you already must have seen or must have gone. So the importance is now the speed of the age, no? So naturally it's have gone, speed of the people have gone. And so naturally the intensity and the speed of the accidents also to have gone. So that's the reason why I've chosen this topic, diagnosis and management of head injuries. I belong to the 75-80 batch. Well, before always we start a topic, it's our custom to pay our respects to the founders of the concerned specialty. So these are the three luminaries who have introduced the neurosciences to the world, to the nation, and to the erstwhile combined state. You know the first one is Harvey Cushing. He was born in the same year as our father of the nation, Mahatma Gandhi, was born. And he made a scientific contribution and strong foundations for the neurosciences, especially neurosurgery, when there was no cautery or even suction. In the early 20th centuries, he operated and then he classified the brain tumors and he established a number of strategies. And he naturally trained a number of students also who have gone across the world and propagated his values and principles. And the next one, I think some of you must be knowing him, is Professor B. Ramamurthy, Balasubramaniam Ramamurthy from Chennai, Madras General Hospital. So this was the second unit in the country. Neurosciences Center was started in Chennai General Hospital in 1951. So he is also the father of our neurosciences in India. A meticulous person, good teacher, planner, an excellent surgeon, and a visionary more than that. And I am sure the son of the soil, Balaparmesrao, Sunkara Balaparmesrao, hails from West Godavari. He started the department in KGH, King George Hospital, Visakhapatnam, I think somewhere in around 1956 or so. He was there for another 10 or 12 years, then he moved out to the Hyderabad Nizam's Institute. A strict disciplinarian. If you want to make a rounds at 8 o'clock, we will be there. Whether the PG comes, house surgeon comes, nurse comes, a different matter. So his discipline was like that. So they have laid the foundations of these sciences in such a way, and the ordeals which they have faced is tremendous. So after paying respects to these great persons, I have not much resume for myself to express. So I will express the boss of the body, that is the brain. You know well, it's about 2% of the body weight, the brain, roughly about 1200 grams to 1400 grams in females to males. And it harbors nearly 100 billion neurons and takes away about 20% of the cardiac output and about 20% of the oxygen. So it's a highly metabolic organ. It cannot survive more than 5 minutes without these two. So that is the thing. Number two, it is still the only organ probably not transplantable to this day. May, in the course of time, things may change. So it's imperative on everybody to protect this valuable one. So just like that, why write an essay question, you just divide these headings, no. That's why I just put these headings like that. So when I'm talking as a traumatic brain injury, it encompasses both the skull, as well as the brain. You know, traumatic brain injury is the leading cause of death and disability associated with trauma. And naturally, no surprise, it leaves behind a number of persons or the population with significant physical, cognitive, and behavioral deficits. Remember, it is the severity of the injuries that decides the outcome, not your high-tech ICUs or the skillful hands of a surgeon, like other diseases. So it's the prevention is the most important in this aspect. In spite of a lot of advances in the last 3 decades in the diagnosis as well as the treatments, still it is a major health and social problem across the globe. Well, a little statistic, 30% of all traumatic deaths, the head injury only, and leaves behind nearly about 5 to 10% permanently vegetative, which costs a lot to the nation. You know well, I don't need to tell, major chunk of this causes is because of the road traffic accidents, followed by the falls and the assaults. A little, just you can see the pointer. Coming? This one? Anyway, there are two mechanisms where the head gets injured when it is going under. Yeah. Last. Yeah. So when the head gets impacted to a surface, hard surface, let it be a road or something or block or whatever it is, then it ricochets back. So this is the one which impacts is the acceleration and ricochets back is the deceleration. And this is what is known as the rotation. So these are the two primary modalities wherein which the brain gets injured following a velocity injury or an accident. In this picture you can see here. So the brain, you can see the this frontal area gets confused, and when the patient goes back, deceleration phase, the brain gets bruised in the occipital area, rough surface of the occipital area skull. So you have this called as the Coop contusion, you have this called as the Caldroff contusion. This is what is known as rotation. This rotational injury is very, very dangerous for the simple reason it leaves behind a lot of deficit to the patient and difficult to recover. It is not amenable for the medical as well as surgical management. This is what is known as impact injury, either a direct hit with a blunt object like that, These are more safe. We can easily manage it because there is nothing, loss of consciousness is not much in these cases. Wait. Come. Some hitch has happened. Where is my cell? వచ్చిందా ఎవరు పెట్టుకొని ఉంటారు అందుకని మంచి నీ మీద నమ్మకం లేదు యా no problem no secrets. Yeah, that's what I told. The closed head injury, this acceleration and deceleration type, and the diffuse axonal injury, which affects the white matter of the brain more commonly, the corpus callosum, peduncles, and the basal ganglia. So this is more dangerous. So what happens in the diffuse axonal injury? It is the diffuse axonal injury. It's self-explanatory, is it not? So across the brain, the axons are injured. How? They got torn in the myelin sheath. So the exoplasm transport is, there is no signals. When there is no signals, patient becomes unconscious. So you can see here, the torn axon here. This is the, dendrites, soma, axons. This is the gray matter, this is the white matter. It's the junction of these two, it gets. You can see the same one here, right? Well, everybody knows that about this scalp injury, abrasion, etc., etc. Skull fractures, of course, basal and calvarial, important. And brain injury can still occur without any impact also, especially in child abuse. Infants and toddlers can get abused by their elders or somebody and impact. Majority of the adults get injured in impact injuries only. Well, what about the pathophysiology? Without knowing the pathophysiology, a clinician cannot do anything because it is the basics. That's why we have physiology, pharmacology, pathology, and then clinical subjects. That's how it went on. So we cannot forget about that. It's not somebody's duty. So what happens? That is the primary injury. So that is not in the hands of a doctor or a consultant. So what is in the hand of a doctor or a consultant or a hospital ICU is to prevent a secondary injury, which is because of a hypoxia or ischemia. So both things must be well protected in order to save the patient. It's not only reaching the deficit is important. So this is what I just brought about. This is the primary insult. And a cascade of events happen, especially when an injury happens. What happens? The capillary endothelium, which you all know well, the specialized endothelium in the brain is not the blood-brain barrier. It is a semi-permeable membrane. which allows only a few solutes and passive oxygen transport. So the oxygen goes and the glucose is allowed to go into the brain cell, but it doesn't allow the high molecular density proteins to go. So when there is an injury, there will be impediment of the circulation. So when the circulation is there, hypoxia automatically sets in. So it breaks the blood-brain barrier. So what happens? The rich proteinous fluid goes into the extracellular space of the brain, and it impinges on the axons and the exoplasmic transmission. So that's what it's. So once it happens, a cascade of chemical events happens. The glutamate, which is a excitator amino acid, it works on the calcium and sodium channels of the cell membrane. Once this fort, as you know, what is the fort? That's how it is. Once sodium goes in, the osmolarity increases naturally, the water will be sucked into the cell. So cell gets swollen. So cytotoxic edema also happens. Remember, this is one is vasogenic, extracellular extravasation of the fluid. Number 2 is cytotoxic. That's what this thing also. You don't need to read all those things basically. Pro-inflammatory cytokinins, free radicals, glutamate, and this cerebral edema, hypoxia, necrosis, cell death, ultimately. Okay. So these secondary events must be prevented at any cost. That's our duty, as far as possible. Well, when you come to the primary damage, which is not in our hands, as I told you, it can be a focal, it can be a diffuse. A focal injury is known as vascular injuries. I mean, 2 elements are there. One is vessel, one is neuron. Is it not? So when the vessel is injured focally, it gives rise to different hematomas: intracerebral, subdural, EDH, and subarachnoid. Axonal injury, I told you already. And a local injury is there, that is called contusion and a laceration. Difference is just only contusion means the pyoglea membrane is means it is torn, but basically the pathology is same. Well, I told you the secondary brain damage. These are the extracranial causes which you should take care of: hypoxia, hyponatremia, hypoglycemia, hypertension. So all these things must be taken care of. This is important. Intracranial causes, I told you, brain edema and of course congestion of the brain. Let's come to concussion. It's a common term used, you know. It is a momentary dysfunction of a brain. That means the person gets injured. For example, he gets a sort of blow to the head. He gets momentarily out of the what you call that dysfunction. So if you grade it, you have the mildest. I'll just simply tell it. Grade 1 is confusion and disorientation. Grade 2 is there will be retrograde amnesia. You know, retrograde amnesia events before the accident, patient forgets. So grade 3 is confusion, retrograde amnesia, and post-traumatic amnesia. Post-traumatic means after the accident. Grade 4 is loss of consciousness. So remember, concussion is not synonymous with LOC. Majority of the times we write in the case sheets LOC present, LOC not present. It doesn't matter. LOC present means definitely serious injury, but not present also is significant injury. It will be followed with these autonomic features as, you know, bradycardia, hypertension, apnea, pupillary dilation, associated factors of the concussion. That's what I told you. You don't leave the patient, of course, when you take CT scan or whatever, plain MRI, everything will be normal with these patients. But they will be keep on coming to your OP after, after 6 weeks or 3 weeks, like there is different complaints. A cognitive, maybe memory disturbances like that, fatigue, easily they get fatigue, vestibular giddiness, ocular sometimes. And of course, common is the neck pain and the post-traumatic migraine. These are the common things. Mood disturbances. These are some of the hypotheses. But remember, the axonal injury is there in concussion also because it has been proved in the studies. The amyloid precursor protein is the marker for the axonal injury. So this axonal damage is proved in the concussion phase. That's why they have all these troubles. It's not that just they are feigning, or it's not a functional element which we just pass like that. But he has some problem. Remember that. Now coming to the edema. What is this edema? Accumulation of fluid in the extracellular spaces of the brain, which I told you. So the brain is such a very soft and pinkish and in situ. So when there is edema, naturally it gets something like a stony feeling it comes, swollen. You know well the Monroe-Kelly hypothesis. The volume in the cranium is fixed in a fused skull. You don't have much liberty there. Maximum maybe 40 cc or something like that. That too, if it grows at a higher speed or a higher pace, the deficits will be more. Slow accumulation can sometimes accommodate even 100 also. And the elderly, fortunately they have cerebral atrophy, you have more space. So brain cannot accommodate itself beyond that 50 ml or 40 ml in a young adult. That's gives rise to our problem, brain edema. So I will not touch much on this. These two important, as I told you, vasogenic because of the injury and ultimately cytotoxic, but both are interlinked. All these things simultaneously happens. It's not one after other going in a queue. Things will roll on. Once a cascade of events happens, it goes on without your control. So that's what I told you. When the CT is done in the brain edema, you can see this hypertensity with a little shift over this ventricle cia. It's later, right? This is how the our knowledge regarding the bookish knowledge, all what I have told so far. Now we have come to the clinical side. The clinical side starts from the evacuation of the patient from the site of accidents. A little over 1.5 decades, this 108 has become a synonymous in all the villages, in all the mandals of combined AP, because it saved a lot of lives. In fact, not only trauma, but different. So whenever there is a phone to the 108, they used to come, pick up the patient, and transfer them to the hospital nearby where they have the facility for something to do it. So this concept has saved a lot of lives, and of course, it has fetched a lot of votes to the then government. Now, helicopter services are also now being pressed in majority of the metro cities here, and majority of the corporate hospitals also have helipads now. Costly, but still. Paramedics must be trained adequately, what they are supposed to do at that level. A scene of accident. Rogers in 1997 said, 40% of the people die on the spot, come what may. Another 20% in 4 hours, that is in the transport time, where the paramedics' role will come into play. So they should see to it that they will not be hypotensive, they should not be hypoxia. So they should have energy, that means sufficient oxygen stores, and colloids, crystalloids, or blood, whatever it is available with them. And of course, in 24 hours after admission also, another 20% die. That's because severe associated injuries also. You know well, head injury patient never presents majority of the time, never and with majority of the times, it doesn't present with hypotension. If there is a hypotension with a head injury means you should look for other injuries. You should not focus yourself a myopic vision to the only head injury and then leave behind. So chest injury is there, abdomen, pelvis, limb. So any fracture is there, giving rise to this hypotension, you should make a mark. So this treatment and diagnosis, A, B, C, D. You don't require to tell all this. Okay. So history, once it comes to the casualty medical officer must be young, energetic, and informative and dynamic. Unfortunately, majority of the corporate hospitals, retired people will be kept there. So they will be on writing. Moles will be writing, injuries will be writing, but you will not be concerned with the patient. So that should not be the trend. Give him enough money or salary to the casualty, because it is the one that keeps the patient alive. Because the first few minutes or few hours or one hour or 2 hours or whatever it is. So they should know how to handle these trauma patients. Polytrauma, in fact. No injury comes with specifically single injury. It will be polytrauma, remember. So you record what happened, what is their condition at the time of. For this recording, the Glasgow Coma scale has been given by Janet and Teasdale. So they have evaluated a uniform scale. Somebody said he is semi-conscious, somebody said he is unconscious, he is drowsy, he is arousable. All these confusing terms has been done with. So they have evaluated a scale, that is Glasgow-Coma scale. You know well, 15 maximum, 3 minimum. So less than 3 will not be there. So if you classify it is mild head injury is 3 to 8 and moderate is 9 to 12 and 13, 14, 15 is the mild. So you can classify according to that. Simple as, you know that Glasgow-Coma scale is, verbal, eye opening, motor response. All trauma patients now, these were before the modern radiology era, wherein you can see the movements or other things. But for theoretical purposes, if there is a hemiplegia, there will be what you call the frontal, injury of the frontal eye field, sometimes cerebral involvement is there. There will be deviation of the eyes towards the opposite side. You know it basically. It is a brainstem or pontine, they will be towards the paralyzer side. So nystagmus, if it is there, you should look for any cerebellar injuries. So see back. Pupils, everybody knows that. Single pupil dilated, that is the area where you have to see for any temporal contusion or EDH. Pinpoint pupils, of course, is unlikely in head injuries because brainstem per se will not be so fast, not injured much. But in case of especially subarachnoid beats and other things, it will be there. Vishnu, remind me in 5 minutes. Yeah. 5 is left? Yeah. So X-rays. Is X-rays now relevant? Yeah. It's not for the skull, but for the spine. And for the other areas, chest X-ray and the limb. Any fractures are there. You must always keep an eye on the chest. That is more detrimental. Head injury associated with chest injury carries bad prognosis. Well, all patients need to be wheeled into the CT chamber. Probably. Who knows? Who is going to have problem? But technically, it is the mild injuries you can still keep under observation. And if you find a deficit, if a seizure is there or so on and so forth, you can wheel them. Yeah, now we come to the crucial phase of this head injury management, intracranial pressure. So this intracranial pressure is around 5 to 15 millimeters of mercury normally. So intracranial pressure is, cerebral perfusion pressure, mean arterial pressure minus intracranial pressure is the perfusion pressure. So blood has to go in. So for it, the intracranial pressure must be at a normal level. So if the intracranial pressure rises, naturally the perfusion comes down. So hypoxia, ischemia sets in. So at all costs, you should keep the intracranial pressure at low. So how do you do it? Because you have a place, CSF can move, blood can move, brain cannot move. But still, the fluid in the brain can be moved. Extracellular fluid, I told you, that is edema. That can be managed. Why? How? There are 2 ways of doing it. One is giving, this is the picture you can see, ankle herniation, transcalvarial, and this is subfalcine, of course, the tentorial. So there are ways of means of doing this intracranial pressure recording is there, but some of the centers where they have high-end facilities, they do it. They may be invasive, they may be non-invasive, not much informative for you. Transcranial Doppler is non-invasive, which can be done. Cerebral flow can be recorded there, and then you can have an assessment of it. So does all patients need to be monitored, whoever is in the ICU? Not necessary. But some guidelines have been given, you can follow, or you can just keep a close observation of the patient is essential, more than all these gadgets. You do rounds in the morning, you do rounds in the evening, and record it, how the patient is. Don't rely on somebody. And if you have an assistant who is reliable, then have a information from him, how things are going on. So you should be very strict in these things. So what are the extracranial causes? You have the intracranial causes, brain edema, congestion you have seen. No. Now these are some of the things which can be manageable. Some of the things which you should keep an eye. This may reduce, increase in the ICU suppose, nurse will be there. No, for 2 beds nurse will be there. for 20 beds, one doctor will be there. That fellow will be moving around, moving the dips and other things. So this patient on ventilator may be going on an occult seizure. He may not be under the ACT, anticonvulsive treatment. So you should have an eye on that. Why this patient is not coming out as per the intensivist strategy. So you keep an eye on that. So all patients on the ventilator, it's better to keep them on anticonvulsants for safe reasons. And let them not buck on the ventilator. So give adequate sedation. So then only they will tolerate. Otherwise they come back and then they buck and then pressure rises. So you should not allow it to go. So what are your goals? These are your goals. So bring down the ICP, maintain the cerebral perfusion pressure, control the intracranial pressure. So that's what I told you. The treatment principles are intracranial fluid volumes. You can reduce it by CSF drainage or cerebral blood volume by hyperventilation, and this tissue water you can buy mannitol, Lasix or Glycerol. And of course, if it comes to that, it is the hand of the surgeon that should save. That is severely badly contused vein or a hematoma is there, you have to evacuate it. There is no other choice. And if it goes beyond that, you may have to remove the calvarium also and put a duroplasty temporarily and then keep the bone flap in the abdomen. So that once the patient recovers, you can replace it without much cost. So this is staircase approach for this intubation, ventricular drainage, mannitol, and of course lost the barbiturate coma. If the patient is not coming out with this, you can induce that. These are all intensivist problems. So that's how I do, this you can see it here. Surgical management, evacuation of hematoma, and decompressive craniotomy. I'll just go through some of these pics here. This is a sagittal cut, this is a coronal cut. This is subarachnoid bleed, extradural bleed, subdural bleed, same thing. In the scan, it looks like that, biconvex, extradural hematoma. It is more middle meningeal vein rather than artery, but still, I consider it as an artery. Subdural, it is the vein. So, extradural, it is the artery. Subdural, it is the vein. Subdural is dangerous because it is associated with diffuse axonal injury. EDH is not associated, it is a focal injury. So, you can salvage EDH patient much easier. So, this is intracerebral. These capillaries are damaged. So, you have three categories. So, arteries, veins, and capillaries. This is how the hematomas happens after accident. This is another variety where there is diffuse axonal. The MRI picture showing the white matter contusions. T2 images, where you can see the hyperdensities here. Corpus callosum, deep white matter, and of course, brainstem also. You can see here, peduncle, right? And the thalamus. Hitherto, we were doing an experimental experiments on animals to prove what these things are happening. Now with the advances in the MRI, these things have happened. You can see reals, you can see this angiography and this perfusion weighted imaging, you can see the perfusion going down. So you can, this MRI spectroscopy, so which can give the any hypoxia or ischemia or anaerobic glycolysis, etc. And is the diffusion weighted imaging, sodium imaging, cellular, everything you can see on the picture, as if you are seeing through the brain. So this chronic SDH, this can accommodate even 120, 130 ml. It usually happens in older age groups, trivial trauma, subdural veins get torn, so slow accumulation over 2-3 weeks. This is some of the operative pics. You can see the nails here, injury, and there is depressor fracture. You can see the hematoma here. This is the depressor bone, this is removed, and a dental plate has been kept. This is how a burr hole is made and a bone flap will be raised. You can see the EDH here, fracture, can you see? And this is the hematoma. So after removing this, you can see the hematoma. This is a leftover, you can do it. This is again EDH. This is how, it's ghastly, is it not? The brain which was pinkish is now almost bluish. It's staring at you, stony hard, subdural, venous blood, very dangerous. The moment you open the door, it just comes like that. So this again subdural. Bone flap fixed with again. So this again, when we do it GCS scale, this is again a GCS scale. It is Genetton bond. That's what Genetton T state. So good recovery, moderate disability, severe disability, and vegetative state. We are worried about the vegetative state, where the patient remains unresponsive to the external stimuli, but he has only a sleep-wake cycle and cardiorespiratory function intact. So this is how physical, cognitive, and emotional. That's what it is. If it's more than 1 month, you call it as a persistent vegetative. So these are some of these chemical markers. Neuron-specific enolase and protein S are some of the biochemical markers where you can assess the injury severity in the body itself. A word about the plasticity. All organs have ability to regenerate themselves to some extent. It depends on the individual organ. Brain too has the capacity because it has the stem cells at the subventricular zone and the gyrus recti. But it's not enough to replace the traumatic brain or the injured brain or following surgery. So plasticity is still at the experimental level. It's not taken care, not advanced as such. If only it has come in a big way, probably all these vegetative patients or degenerative diseases, Parkinson's, Huntington's, chorea, etc., no? All these things will not be, Alzheimer's, all these things will not be there. Well, what will do it? This is the most important slide among all those things. చేతులు కాలేక ఆకులు పట్టుకునే దానికన్నా ముందు అసలు చేతులు కాలకుండా చూసుకోవడం ఇంపార్టెంట్. So that's what the government should do. The press perhaps always do something which they like. No, but public also. But our effort should be in this direction to educate the public and to educate the government and to educate the media and educate ourselves. Because this is the one, drunken driving and speed. Unfortunately, it is the young age group, 15 to 30 years of the group, they get maximum impact in these head injuries. No, valuable life is lost. And if it is lost, it's okay, people forget in a month or 2 months. If it becomes vegetative, then it's a big burden to the family. So you should be very careful. You should tell your wards, children, not to go at high speeds, drunken driving, etc. Don't take things lightly. Value your head. Not everyone gets a second one, unlike Ganesh. So you drive safely, and you are the key to your safety. Thank you. Thank you, Vishnu. Huh?
That is Dr. P.S. Reddy. Simple, clear, no nonsense talk on the head injuries. We appreciate you. Thank you.
Thank you very much. Thank you for this. It's an honor and a privilege for me to be here to interact with you. Thank you very much for patient hearing.
సార్ రీసెట్ చేస్తున్నానండి ఎందుకంటే డిస్ప్లే కెమెరాతో ఇచ్చాము డైరెక్ట్ లైవ్
Okay.
మీరు ఇచ్చింది సార్
Restart.
ఓకే సార్.
This is Dr. Vandana, announcement from the SPM department of RMC.
Very good morning, Rangarayans. I am Dr. Vandana, second year postgraduate from Department of Community Medicine, and I am here to inform you that for the first time in the history of RMC, a national conference is being organized here by the Department of Community Medicine. It is the 63rd annual national conference of IPHA, the Indian Public Health Association. The theme of the conference is Health and Hygiene Hand in Hand for a Swasth Bharat, commemorating the one. So I invite you all to please register for the conference. We have a stall just outside the entrance of the auditorium. There will be several orations, 6 orations, 12 plenaries, covering some major public health topics on communicable diseases, NCDs, mental health, mother and child health, adolescent health as well, and even one session on air pollution and its effects on health. So once again, I invite you all to please register for the conference, and even if you're not having the time enough to attend the conference, please donate liberally for the conference. This is the first national conference I would like to mention once again to be held in RMC. The dates of the conference are from 31st January to 3rd February 2019. So I welcome you all once again to the conference. Thank you. One more thing I would like to mention that the conference is giving about 6 plus 2 credit hours, 6 hours for the national conference and 2 hours for the CME to be held on 31st of January. There are four different sessions in the CME, one on team building and leadership skills in health professionals, systemic reviews and meta-analysis, and another session on, by UNICEF, there is a session that is WASH, and there is another session on neonatal health care, sir. So those are the CMEs which carry 2 credit hours, and the national conference carries 6 credit hours. So that's it, sir. Thank you.
So we have some more technical issues here, but let me take the opportunity to introduce the next speaker. He's the youngest in our batch. His name is Dr. N.S. Raju. If one of my colleagues whom I can be very proud of, that is him. He's doing such a humanitarian care to the needy people in Andhra Pradesh. It's not an exaggeration to say maybe he's one of the top palliative care specialists in this area. He told me yesterday, palliative care is not end of life care. And he gave me a hint, I don't want to go as a last speaker, bring me back. So we brought him up a little bit. I hope he's going to enlighten us how we can treat patients with end of life with the dignity and care. They don't need sympathy, they want empathy and passionate care, compassionate care. So it's almost there. Oh. Yeah. His father used to teach us botany, Ganapath Raj garu. Ready?
I invite Dr. Kameswara garu, Dean, Professor of Anesthesiology, KIMS, Amalapuram, to be the chairperson.
So we have the computer is back, but we don't know the password. Just give us a few minutes.
Good morning, everyone. First of all, let me thank the organizers for giving me the opportunity to chair this session with which I am very much interested and associated also. Since 2001, I am running the Palliative Care Center, and 2005 I established in Government General Hospital, Kakinada. Even till today, this is the only center palliative care in the government setup in the entire Andhra Pradesh, and it was opened by the ex-Chief Minister Rajshekar Reddy garu. And similar services I am continuing at Konasema Institute, Amalapuram from 2016 onwards. And this is a very good topic, essential for everyone. People think palliative means cancer patients. Palliative means it's not the end stage life. It starts from the treatment diagnosis, continues during the entire period of treatment till the end of the life. That is the palliative care. It is a symptom care and a soothing care, comfort care that is offered to the patient till the death. It may be a cancer or it may be other conditions like Alzheimer's disease or a COPD patient or a heart failure patient or whatever, or amyotrophic lateral sclerosis like neurological diseases which require a continuous care till his death. That is the importance of palliative care, and unfortunately these services are very less in India, having billions of population, only 900 in that around 800, more than 800 are in Kerala state. Only rest of India, the remaining 100. That means the service is available only for 3% of the population, and still so many palliative centers are required in India. And N.S. Rajgar is doing a wonderful service at Visakhapatnam, and he is doing hospice care also, and his talk is very beneficial and useful for everyone. Now, thank you, sir.
Thank you, Vishnu, for the kind introduction. My deep gratitude to all of you for being here today, and I feel very honored and privileged to be among you. I thank the organizing committee for organizing this wonderful CME today, and also for giving me this opportunity to speak on palliative care. It is indeed a pleasure to welcome you all for this session on palliative care, living as well as possible for as long as possible. I know actual or potential conflict of interest. I have a few disclosures to make. Many times I fail to live up to the introductions. That's one. The second thing is I am not a specialist in palliative care. I am a serious student of this discipline, and I can be called a generalist. Later on in the topic, I will tell you what is generalist. Nine-year-old Karthik. Times of India reported that this boy was getting treated in a small hospital in a remote district of Kerala. He died at the hands of his parents. The parents then hanged themselves, and the police found a suicide note saying that they couldn't bear, they couldn't tolerate the pain the boy was going through. Here I will pause my presentation for a moment. If there is someone sitting in the room, I am sure most of us would have gone through a serious illness experience in our families. Somebody we love passed away with a lot of unrelieved pain or suffering. And we would have felt that the system really didn't do enough. I know that it's not easy to discuss these topics because it always tends to reopen our old wounds. It's difficult. But if someone can speak on that, I'll be very happy. It will be benefiting everyone. Anyone who can speak about something that happened in their family where they felt they couldn't do enough to keep them comfortable at that point of time and still carry the guilt now. Anyone? It's okay. Dame Cicely Saunders, a British nurse, seen suffering in her hospital, resigned her job, became a social worker, then thought that she cannot fight this system from outside. She went to the medical school, became a physician, and she is known as the founder of modern hospice movement. She established the very first modern hospice in the suburbs of London. It's called St. Christopher's. My respects to Dr. M.R. Rajagopal. He happens to be a mentor to Sir also, long back. You might have been trained about 10 years back, sir? Yes, sir. He is generally referred to as a father of palliative medicine in India. He is an anesthetist by training. So for his outstanding work for palliative care, he was awarded Padma Shri in the year 2018, and he was also nominated for Nobel Peace Prize. So let me begin with some very good news and a bit of bad news later. So good news first. The life expectancy has risen dramatically during last century after being more or less flat for almost 30,000 years. So what was the reason for this dramatic improvement? Anyone? Any guess what made this possible? Antibiotics. Good. This is generally what we get from a group of doctors, but unfortunately not. It is because of public health. Safe drinking water, better sanitation, and good nutrition. The antibiotics, immunization, and maybe advances, improvement in reduction in infant mortality contributed a little. The antibiotics are supposed to have contributed about 5 years to the longevity. And the modern medicine, maybe about 3 to 5 years. Am I right, Clark? The modern medicine, all the ICU care and all that would have added between 3 to 5 years of this longevity. The greatest contribution is of public health. So life is long and wonderful, but unfortunately life is limited. So that's the reality we all live with, and that brings us face to face with living with serious illness and chronic illness. So coming to the bad news, the world death rate is holding steady at 100%. In spite of all the advances in Medicare, all the technology, all the interventions, all the diagnostics, still holding very steady. And worse, there is no real plan to change it in the near future. So it's very interesting to look at the historical perspective, to see what longevity has done to our illness experience and even end of life. 100 years ago, there was really not much of chronic illness or serious illness. Why it is so? They did not have diabetes or hypertension for long. There were no treatments, and death used to come suddenly and unexpectedly at a very young age compared to what we see today. So usually illness experience was very brief, maybe days, maybe weeks, maybe months, but not years or decades that we experience today. So what about today? Today things are very different. Treatment for serious illness help people live very longer with even good quality of life. Exacerbations and hospital admissions are the norm, and death comes after years or even decades of serious or chronic illness. So what is the challenge? The challenge is to help achieve people good quality of life for as long as possible in line with their preferences and goals. Can we, for a moment, imagine our end of life? I give you a little time, close your eyes, just imagine in your mind what it will be like. Modern medicine at the fullest, lying alone on the bed, lots of monitors, devices all around you, troops going in and out. Is this what we want for ourselves or for our loved ones at the end of our life? Anyone? And can we do something to make it different for people who do not want to end up this way? Long back, Eric J. Cancel said this: the relief of suffering and the cure of disease must be seen as twin obligations of the medical profession that's truly dedicated to the care of the sick. Failure to understand the nature of suffering can result in medical interventions, though technically adequate, not only fail to relieve the suffering, but can also become a source of the suffering themselves. This is a very nice article by Atul Gawande. It came in New York. If there's someone in this room who has not seen or read Being Mortal by Atul Gawande, please do. Not for the sake of your patients, but for yourself and your loved ones. What he says in this article is there is mismatched care for chronically ill people. So what happens is many times people receive care which they do not want and from which they will not get any benefit. At the same time, patients do not get the care that they want and from which they could have actually got benefited. So today we are going to discuss briefly about definition, why palliative care is important, and the constituents or components of palliative care. There is one take-home message which has been given away by Dr. Vishnu. Thanks for that. What palliative care is not about. Palliative care is not about end-of-life care. Yes, end-of-life care is a small, important part of palliative care, but palliative care is not just end-of-life care. At the end of the session, if you just carry this message, the purpose of this session is already served. World Health Organization has defined palliative care as an approach, not as a discipline. It's an approach. Coming to the most important thing, it improves the quality of life of the patient. We are not talking about prognosis, how long he will die, whether he will die. We are not talking about that. We are only talking about improving the quality of life of the patient. Another important thing, we are not talking about the patient alone. The unit of care in palliative care is always patient and his or her family. Patient and family comes as a single unit for care delivery in palliative care. So for whom it is appropriate, the definition says life-threatening illness. This has been changing. The scope of palliative care is expanding many times now. At one time we were talking about only cancer, then it was about terminal illness, then it was about life-limiting illness or life-threatening illness. We are now talking about serious health-related suffering. Wherever there is serious health-related suffering, palliative care is very, very appropriate. The last thing, if we come to the last few lines, palliative care recognizes that the suffering is more than physical. So palliative care tries to address the psychological, emotional, and also spiritual causes of suffering. So to whom palliative care is appropriate? It can be appropriate at any age. It can be appropriate for any diagnosis, whether it is curable or incurable, any stage of the disease, any prognosis, and most importantly, any care setting. It can be delivered at home, in a hospital, in an emergency department, in an institution like old age home, in a hospice. So what are the diseases which are likely to get benefited by this? Of course, malignancies, neurodegenerative diseases, take Parkinson's, motor neuron disease, various kinds of dementias, organ failures, congestive heart failure, end-stage renal disease, liver failure, respiratory failure, COPD, frailty, no specific diagnosis, of course HIV/AIDS, and many, many more. The list doesn't end here. I would like to present the model of palliative care, the present contemporary model of palliative care. Palliative care is something that should begin at the time of diagnosis. For the best benefit of the patient, palliative care team should come in at the time of diagnosis. You can see it progresses as the disease progresses. Sorry. So from the diagnosis, it goes hand in hand with disease modifying therapy as long as the disease modifying therapy is appropriate. The focus between palliative care, palliative medicine and curative care may vary at different times of the course of the illness, but they are always there. So palliative care should ideally start at the time of diagnosis, should continue along with the curative or disease modifying therapies as long as they are appropriate till the end of life. And then subsequently, it will continue to care for the family for some time as bereavement care. So palliative care can be delivered concurrently with the life prolonging therapies, but sometimes when disease modifying therapy is inappropriate or not available, or because the burden of the treatment is so much that patient cannot stand these curative therapies, then palliative care will become the single focus of for the patient. So palliative care can also help the family and the patient when he is going through transitions in goals of care. See, the patient always the treatment starts with the intent to cure. At some stage, the team will decide that cure is no longer possible. Now let's try to prolong life. This is a very important decision for the family and the patient. So palliative care is always there to take care of the transition. And at some point of time, even this life prolongation may not be possible. That time again the goals shift to end of life care. Again palliative care is very appropriate at that point. Also please understand that in certain situations the curative therapy will happen even on the last day of the life of the patient. For example, take the case of congestive heart failure. Even on the day when the patient dies, the patient will be getting a diuretic and maybe a ACE inhibitor. So it is not like only either palliative care or disease modifying therapy. They go hand in hand for the benefit of the patient. So is there any evidence for this? Randomized control study at Mass General Hospital, Harvard, that took 151 patients with non-small cell carcinoma of the lung, a disease that is incurable at the time of diagnosis, and all of them were on line 1 best chemotherapy, standard chemotherapy. 50% of them were randomized for receiving concurrent palliative care along with curative therapy or disease modifying therapy. So what is the result, the outcomes? They had all good things that can happen to a patient. They had better quality of life and they had surprisingly survival benefit. So they had better symptom control, they had less depression, they had less interventions during the last days and weeks of life, like an admission into the ICU or maybe a chemotherapy in the last few days of life. And they had a 2.7 months survival benefit in the group that was assigned to palliative care along with standard chemotherapy. Don't look down on 2.7 months because this 2.7 months is more than what chemotherapy offers to these patients. So this is as good or even better than the benefit offered by chemotherapy alone. So what is the burden of this health-related suffering? This is a Lancet Commission report, 2018. Every year, approximately about 25.5 million, half of all deaths, these patients had unrelieved health-related suffering. 25.5 million global figure. And add to this another 35 millions of people who are not dying at that point of time, but having serious illness. Add that. Another problem is 80% of all these patients who are suffering, they are in low and middle income countries where they have no access to palliative care, and even the availability of morphine for pain relief is very, very limited. So what the patients need? How much time? Palliation of symptoms, clear communications, and psychosocial support. So what is the prevalence of symptoms? Huge. Fatigue 74 to 90%. Pain is between 60 to 76% in cancer patients. Let's look at the prevalence of symptoms in non-oncological conditions. Surprisingly, the symptom burden in non-oncological conditions can be as much or even more than what we see in cancer. Look at depression. Depression is about 5 to 60% in CKD. Pain in heart failure is between 41 to 77%. Don't be under the impression that this pain is anything related to the heart. But this heart HF patient generally comes from an elderly age group. He'll have comorbidities, arthritis, or maybe diabetes causing neuropathic pain. So these patients have pain for other reasons also, not necessarily for the underlying cardiac condition. So fortunately, many of these symptoms can be palliated, controlled with minimal interventions, either pharmacologically or non-pharmacologically. So communications is such an important part of palliative care. They are actually part of a clinical practice. There is enough evidence about the therapeutic benefit of these conversations. Communications can be difficult. I have a small clip. Can I have some more audio, please? Audio? Can I have more audio? More audio? Volume? Well, leave it for saving time. Leave it. How much time a mammal will take to pee? Anybody has an idea? How much time a mammal will take for a pee, passing urine? Irrespective of the size. Prostate. Wrong. Yeah, prostate is right. Irrespective of the size, it is about 11 seconds. Yes. There's a study on that. This is what Americans do now. Double-blind study. And very interesting. Do you know how much time a patient will get while talking to the doctor before he gets interrupted? 11 seconds. So patient will not get the kind of time that he takes for a pee when he is talking to the patient. So listening is such an important part, and That's one of the skills that are imparted to palliative care physicians, to listen. So these are all the communication scenarios. For want of time, this presentation is available. I think Dr. Vishnu will do something to pass these presentations to whoever are interested. So these are very important topics to be discussed between the patient and the doctor. And these discussions are very, very important, and they're associated with better quality of life near death, fewer invasive interventions, and better outcomes for the caregivers. The psychological support includes assuring the patient of non-abandonment, which is the fear of the patient who is going to die is not about death. It's more about fear of abandonment, fear of suffering. We have to understand that. Then hope. Don't be under the impression that what hope somebody who is going to die will have. No. Patients have priorities apart from just living longer. So hope, not destroying hope. And bringing closure to important relationships, very important. There's a good 4 things which, there is a very nice book, I will send the reference, and spirituality. So the resources are available in the palliative care world to guide you in the symptom control. The palliative care scene in India, 3 minutes. It is a dismal, less than 1% in India. Kerala, which has 3% of India's population, has got about 80% of all palliative care initiatives that are available in this country. 80%. Access to palliative care is between 50 to 60% in Kerala. And the Kerala model of palliative care has been recognized by the World Health Organization to be emulated in the developing world elsewhere. Morphine, the gold standard drug, not available in most part of the country. So what is required to improve the access? Policy, drug availability, and education. Generations of Indian doctors and nurses came out of this medical and nursing schools without having using narcotic analgesics. That is because of a stringent law which came into effect in the year 1985. The use of morphine decreased from 716 kg in 1985 to 18 kg in 1997. Because of the efforts of all these people, civil society and judicial intervention, things happened. 2012, central government has declared palliative care policy, and 2014, a landmark amendment to the Narcotics Control Act happened in the Parliament. There is no good indicator for the access of palliative care. Palliative care is not about just pain relief, and pain relief is not about just morphine. But morphine equivalent of strong analgesics, the consumption, is still considered as a good indicator for the access of palliative care. Consumption of morphine or its equivalent per cancer death is 444 milligrams in India as against 2,73,526 milligrams in USA. To make it simpler, the per capita consumption of morphine is 0.24 milligram in India per person per year, annum. It is 496 milligrams in USA. Okay, USA has got its own problems with narcotic opioid backlash. About 155 persons dying a day because of misuse. Leave USA. Take Europe. Take Australia. 210 milligrams in Australia per person capita, as against 0.25 milligrams in India. And India is the largest, one of the largest producers of opium in the whole world. Gets exported. 90% of the medical morphine is used by 10% of world's population. Take an example of Tata Memorial Hospital. Total number of patients 3.4 lakhs. If you take 70% having advanced disease, 2.38. If only 60% of them need morphine for just 3 months in their lifetime, and if they take just 70 milligrams per day, the consumption for only Tata Memorial Center is 1,017 kg per year. And in the year 2014, the total consumption of morphine is 300 kg. Did I make my point clear? This is the World Health Organization pain ladder, came out in 1986, appropriate even today. It was not part of our curriculum, it was not part of our practice even today. So these 3 stages approach which is necessary for each and every one of us, not just us. Our paramedics, our nurses, our ward boys, our even caregivers should know the approach to palliative care. I said I am not a specialist, I am a generalist. Someone with a little more training, a little more experience, and a little more learning. Each and every one of you sitting in this room can become a generalist. Should become too. So what does the general palliative care do? Basic pain and symptom management, goals of care discussions, family meetings for decision making, and decisions about stopping treatment. This all of us should be able to do. These are all the institutes which can provide such training for us. Now, palliative medicine is MCA recognized as a specialty in 2010. There are now 2 institutes providing MD palliative medicine, All India Institute of Medical Sciences and Tata Memorial Center. GCRA has just got the approval now. This patient is in this position for how many days we do not know. Not having sleep, not having anything drink or eat. All it took is 10 milligrams of immediate release morphine costing 2 rupees 50 paisa before he could have his first cup of tea in days. So we have the drugs, we have the knowledge, we need the will to do this. Do we have time for a 2 minutes video by any chance? Thank you very much for this opportunity. Thank you very much for the patient hearing. And I look forward for some of you to come out with something. We need people, individual doctors or from institutions or from NGOs to come forward so that palliative care initiatives can start in other parts of Andhra Pradesh. As far as I know, there is only 1 or 2 organizations working for the whole state of Andhra Pradesh. That's a pity, that's a shame. Thank you. Can you just remove the paper?
Is known to everyone.
It's a very, Sir, Dr. Rajgopal is a great visionary. Please don't compare me with him.
You also will become in time, don't worry. Mike తీసుకొచ్చావు
So we have, if you are all patient, if you are not feeling that hungry, we have one more speaker before lunch break. And then you can take a lunch break, shorter lunch break and go home early, or a longer lunch break and stay longer. The choice is yours.
We'll have another speaker.
Yeah. So the lunch may not be ready. Oh, the last speaker came. I thought I will let you go home in half an hour before the last. Okay, now I invite Anil Goganeni to come onto the stage. He's a practicing pulmonary critical care doctor in Ocala, Florida. He's board certified in internal medicine, pulmonary medicine, critical care medicine, sleep medicine. What else? Etc., etc. So, obstructive sleep apnea is a very underdiagnosed but very important condition. So, I request Anil to enlighten us about obstructive sleep apnea and its consequences on the various systems of the body. Thank you.
I request Dr. Ramkrishna Garu, Senior Pulmonologist of Kakinada, to be the chairperson.
Thank you, organizers, for giving me this opportunity to chair this session. Obstructive sleep apnea is a very interesting topic that is gaining a lot of popularity of these days. Obstructive sleep apnea, where the mainly snoring becomes a major problem, where it is comfortable to the snorer, but very uncomfortable to the partner. And there is always a grouse from the partner that his or her spouse is snoring. Very interesting topic. Right, gentlemen?
If there are any diabetics, if they're getting hypoglycemic, they can take a little break and go and eat, and other people can stay here. I said only diabetics, not the surgeons.
Good afternoon, everybody. Thanks for coming to this great CME program, and thanks for giving me the opportunity, Vishnu Garu and Jawahar Garu. Okay, and today I'm going to talk about sleep disorders, especially I'm focusing mostly on sleep apnea. And when I was thinking of doing the presentation, I was thinking the differences between the place where I'm practicing and the talk where I'm going to give. So I reviewed a few articles and looked at around, and I came to a conclusion that the management is little different and the diagnosing part is more different compared to our US way of diagnosing, because the lack of facilities and other things. But in overall, the way how we diagnose and how to treat and how to follow the patients, basically I'm going to go over that. That's good. So, the objectives of this talk are to review the basics of sleep and sleep disorders and describe the pathophysiology, mainly for the obstructive sleep apnea, review the risk factors for the development of sleep apnea, evidence for sleep apnea contributing to other systemic disorders, screening for and also diagnosing sleep apnea and various sleeping aids and management aspects. So, basic information. The sleep, when you see the graphic representation of sleep from infants to adults, the stages are stage 1 to 4, and 1 and 2 are the first initial non-REM sleep, and slow wave sleep and the REM sleep, and wake onset after the sleep onset, and sleep latency. So when you get older, the sleep onset is normally it starts with non-REM. But sleep latency, it increases with age, and wake onset after sleep onset is basically increases with age. And stage 3, which is N3, decreases with age, which is a deep sleep, it goes down, and REM sleep also goes down. Total sleep time and sleep efficiency, everything goes down when you get older. And in the basic, when you see the sleep studies, N2 occupies most of the total sleep time. And the delta power, which is the N3, is the highest during the initial REM sleep, and which basically is crucial for our sleep consolidation also. REM sleep and REM density increases in the later part of the sleep, and the second half of the sleep has more REM and also N2 sleep. So when you see the graphic representation, that green part, which is the REM sleep, the the density goes up when the night goes on, and the rest of the sleep stages goes down. And there are about 3 to 4 cycles of cycles goes on in the whole night, and which includes first cycle with low REM sleep, and when you see the last cycle, it will be the highest amount of the REM sleep. So when you look at the overview of sleep disorders in the US, there are about 100 million Americans suffering with sleep disorders, out of around 350 million people. And out of those, there are about 84 disorders are diagnosed, and half of them, out of 100 million, 50 million people are suffering with insomnia. And restless leg syndrome is about 20 million, and obstructive sleep apnea about 12 million, and rest of them, which are not shown here. But most of the disorders are underdiagnosed too. So cost, when you look at the cost, this was a study published from Australia. Australian population is around only 30 million, and for them, there's about 10 billion dollars spent on the sleep-related disorders. It could be from diagnosing part, or it could be work-related injury, or it could be loss of productivity, and most of the thing is from premature death. And this was published in US AASM, undiagnosed sleep apnea. It's considered a hidden health crisis, which is also saying about 150 billion total money is spent related to same work-related accidents, motor vehicle accidents, lost productivity, and other comorbid disorders, which are undiagnosed. So a lot of money which is spent on this kind of disorders. So what is sleep apnea? When you talk about pathophysiology, when the people goes into sleep, they increase the breathing effort. With that, their PO2 goes down. Sorry, PO2 goes down, PCO2 goes up, and eventually they goes into arousal phase, and they start hyperventilating, and then later on they come back to sleep, and cycle goes on. And based on this, there is a therapeutic options are, a lot of options are in the research phase, like how to increase the arousal threshold. And most commonly what we use is CPAP, and there are some other medications are trying to be in the research process now, but currently what we have is mostly CPAP. So what is the prevalence? Based on this Wisconsin cohort study, in that study, the AHI, how much is the apnea-hypopnea index, makes the prevalence difference. If it is the AHF more than 5, it is prevalent in about 24% of the adult men, about 9% of the adult women also with the diagnosis of sleep apnea. But if you talk about sleep apnea higher with more than 5 with symptoms, which is called obstructive sleep apnea syndrome, 4% of adults are with the diagnosis of sleep apnea, and 2% in the women. So I looked at prevalence in India. This is published in the Indian Journal of Medical Research in February 2010 by Dr. Sharma and Ahluwalia. The prevalence of the sleep apnea is 9.3%, but when you separate it, in men it is 13.4%, and in females 5.6%. If it is obstructive sleep apnea syndrome, the prevalence is in male 4 and females 1.5, which is close to other studies published in US also. So I want to mention one thing here. The obesity is the main issue here to talk about metabolic syndrome or syndrome Z, which is sleep apnea with metabolic syndrome. So in USA there is a law which was brought into effect recently, but it was struggled to come into this law for the last 8 years. Initially, Obama brought this. The calorie count needs to be displayed on each and every food when we eat in the restaurants. So this came into law about 6 months ago. And with that, if you know what you're eating, how much calories you're eating, that will give you an idea how much weight you can gain or how much weight you can lose if you strictly follow the amount of calories you're eating. So if you eat 100 calories less per day, by the end of the month, you lose 300, you basically not eating about 3,000 calories. By the end of the year, you might lose about 8 to 9 or 10% of your weight, which is close to 10 kilos. So basically the purpose of doing that is to educate the people and to focus what they're eating. Actually, we are putting a couple of plexis in the conference this weekend. You can see the more information about it. Basically, our goal is to send these messages to most of our physicians, doctors, everybody, and students and everybody, to talk to their parents and show it in their offices to educate, and also to talk to the government people to see if they can come up with a law which is similar to what we have. After struggle for many years, we came up with this law. So when you talk about spectrum of sleep disorder breathing, it starts with quiet breathing, which is normal, and intermittent snoring, chronic heavy snoring, upper airway resistance syndrome, mild sleep apnea, moderate and severe. So what is apnea? It's the absence of airflow at the nose and mouth for about 10 seconds or more. Then that's called sleep apnea. There is hypopnea, which is a lesser reduction of the airflow, and nasal pressure signal by about 30%. I'll show you the graphic also, for 10 seconds or more, associated with about 4% drop in the oxygen saturation. And obstructive sleep apnea, in obstructive sleep apnea, there is respiratory efforts are present. But in the central sleep apnea, the efforts are absent. So this is the graphic representation of the obstructive sleep apnea, mixed apnea, central apnea, and hypopnea. The airflow is absent with the presence of respiratory effort in obstructive sleep apnea. Mixed, you can see the partial loss of respiratory effort. And in central apnea, everything will be lost, both airflow and respiratory effort. And hypopnea, the percentage of the signal will go down, which is about 30%. So the obstructive sleep apnea is, the determination is based on number of apneas and hypopneas per hour. This is called apnea-hypopnea index. And there are RERA, we call RERA, which is respiratory effort-related arousals, which means the arousals associated with increased respiratory effort for more than 10 seconds, which are not classified either apnea or hypopnea or central apnea. And RDI, meaning respiratory disturbance index, which is normally we give it to the people which they do a home sleep study, because in that study that the index is given for the total sleep bedtime, not the sleep time, because we don't record the EEG. So how do you diagnose sleep apnea? When apnea-hypopnea index is more than 15, it is diagnosed as sleep apnea and needs to be treated. And if the RDI is also more than 15, which is done in a home study, with a minimum around 30 events, that's considered sleep apnea, needs to be treated. And if it is apnea-hypopnea index or RDI more than 5 with associated symptoms, with a minimum of events of 10. What are those symptoms? Excessive daytime sleepiness, mood disorders, impaired cognition, and insomnia. And also, if the people are with, the patients are with hypertension or ischemic cardiac disease, pulmonary hypertension, stroke, these are all considered the patients with a high risk needs to be treated even though the index is low, which is more than 5 with symptoms. So the other symptoms which are not in the essential diagnosis, but they come up with these symptoms when they come to the doctor: unrefreshed sleep, fatigue, the awakenings with breath holding or gasping, choking at nights, observed by other patient's family. Bed partners report of loud snoring and breathing interruptions during the sleep. Severity of sleep apnea is classified into 3, which is mild, moderate, and severe. Mild is around 5 and 15. Moderate is 15 to 30, and if it is severe, more than 30 events per hour. And you also need to focus on what other things are happening in the sleep study. What is the lowest desaturation? What is the nocturnal, what is EEG showing? Any significant arrhythmias? Any long apneic episodes? Any degree of excessive daytime sleepiness? Those needs to be considered in terms of making the diagnosis and also in terms of management. So what are the risk factors? The multiple risk factors will be shown. I'll show you each and every one. So first thing is gender. Males are at high risk, around 2 to 3 times more than females. Menopausal women are at high risk, which are close to their age-matched men. Aging also increases the risk up to age 40 to 60. That risk is higher. After 60 is equal to the other age group people. Smoking, heavy smokers, they tend to have some increased risk of sleep apnea because of the probable upper airway inflammatory changes, edema, and other stuff. And alcohol also one of the risk factors. And people with hypothyroidism, especially women more than 60, are very common. It is about 1.6% of obstructive sleep apnea people are with hypothyroidism. So everybody with hypothyroidism, you need to screen for sleep apnea, and vice versa too. Acromegaly, are people are with acromegaly, they are at high risk for central sleep apnea with some obstructive component too. Ethnicity, it's very common in people with Asians, Chinese side, even though they look small, but their anatomical problems probably putting them at their high risk. And African Americans and Mexican Americans. Very commonly, craniofacial abnormalities, malformations are the etiologies for sleep apnea, which includes the size of the neck. If it is more than 17 in men or more than 16 in women, they are at high risk. Microglacia or macroglacia, retrognathia, micrognathia. So a lot of other anatomical problems from the craniofacial area. So this is the example of prognathism and retrognathism. The left-sided, this is before surgery, that's after surgery, same thing before and after surgery. You don't need to treat for sleep apnea if you treat the anatomical problem. There are other hereditary symptoms you need to focus on. So very commonly we talk about the sleep apnea is related to obesity. Obesity, the people with 35 and above, they are called high risk for sleep apnea. But there is a study published in year 2000 by Nieto et al. What they're saying is majority of subjects with apnea-hypopnea index more than 5 are not obese. So if you see that graphic here, only 45% people are obese with sleep apnea, but rest of the 55% not obese. They are either overweight or mildly obese. So you need to consider other anatomical problems, or maybe one of the reasons it's not necessarily obesity. So the other factors about obesity, 10% of the increase in weight is associated with 32% of increase in AHI. And again, 10% decrease will go down with your AHI reduction to about 26%. So weight loss is the primary event, which is a conservative treatment. And abdominal girth itself is an independent risk factor. If your abdominal girth at the level of your navel, if it's more than 102 centimeters or 40 inches, you are at high risk for sleep apnea, it needs to be screened. And as I said before, neck circumference. One question, if you want to, which of the following is correct regarding sleep apnea in women compared to men? Men and women with similar BMI will also have similar AHIs. Non-REM AHI in women tends to be lower than non-REM AHI in men. REM AHI in women tends to be lower than the REM AHI in men. And the last one, women tends to have more severe oxygen desaturations with obstructive events than men. Anybody wants to raise their hands, which one's answer? But I'll go with the answer. So I'll go with the details. The answer is basically B. The non-REM AHI in women tends to be lower than non-REM AHI in men. But in the REM sleep, the woman acts like men, so there is no difference. Women tends to have more severe desaturations, which is wrong. The other way is right. And again, same thing. Women have higher BMIs for similar AHIs compared to men. So we talked about snoring. So 85% of the obstructive sleep apnea people snore. So what is the prevalence of snoring in that different age group? About 10 to 12% of children snore. Middle aged about 20 to 40%. In the older population, almost 50% on average. And sleep apnea is present in 35 to 85% of the snorers. So it's a broad range. It's hard to say who is having sleep apnea or not, who is not. So again, the snoring itself has some independent risk factors. Obesity itself, sleep deprivation, supine position, nasal obstruction, and some medications, mainly commonly alcohol. And loudest snoring is seen during N3 sleep and mildest during the REM sleep. And common intervention we do is putting oral appliance. So when is the snoring is a more than just snoring, and when somebody with snoring, if in having like one of the other symptoms like daytime hypersomnolence or obesity or hypertension, they'll be at 78 to 95% higher risk of having sleep apnea, and sensitivity is significantly high. So what are the symptoms? Big range of symptoms you see very commonly: EDS, excessive daytime sleepiness, non-restorative sleep, frequent awakenings, insomnia, morning headaches, loud snoring, gasping, choking at nights, partners complaining, which is the commonest thing. We need to talk to the people who are coming with the patients. Lack of energy, impaired memory, concentration, dementia, irritability, mood changes, nocturia, restlessness, and erectile dysfunction. If you say that, and people will be more likely to be compliant with the CPAP. So number of studies have shown that number of transient arousals, arousal periods and the severity of hypoxia correlate with the severity of hypersomnolence. So that's the reason I mentioned before, you need to see how much the desaturations and how significant it is on the sleep study also needs to be checked. So clarification of some symptoms. So excessive daytime sleepiness is the classic symptom of sleep disorder breathing. And severity of excessive daytime sleepiness does not correlate with AHI. So you need to be cautious when you're assessing the patient. And EDS is also associated with other sleep disorders like narcolepsy, very common, which common to us when as a specialist, chronic sleep deprivation, and shift worker sleep disorder. And fatigue, seen in a lot of other disorders. So when you talk about fatigue, you need to rule out other etiologies like hypothyroidism, fibromyalgia, other endocrine disorders like that. And common symptoms you see in women with sleep apnea, other than what I mentioned about before, insomnia is very common, and depression, fatigue, morning headaches, lack of energy, and less witnessed apneas compared to men. Maybe we are afraid to complain about it. Maybe. So in children, attention deficit, hyperactivity, decline in performance at school, nocturia, snoring, and obesity. When you see these things, you need to get some evaluation and do appropriate intervention. So why treat sleep apnea? That means what are the consequences if you don't treat? So this is the graphic representation showing what are the consequences. So first thing is in this side, what are the primary events in the sleep? And these are the physiologic consequences, and these are the clinical features. So when you see sleep onset and then you develop apnea, and your oxygen goes down, your carbon dioxide goes up, pH goes down, and after that you arouse from the sleep and resumption of the airflow and return to sleep again. So this is the cycle which I showed you before in the pathophysiology. So each step, what happens? When your oxygen goes down, carbon dioxide goes up, you'll have a vagal bradycardia, which leads to ectopic cardiac beats. And these are the common, this is the common reason for unexplained death early in the morning. And pulmonary vasoconstriction, which leads to pulmonary hypertension, and eventually at some point, right heart failure is not treated. And even though it's a pulmonary hypertension, it's a mild form, it's not severe. If it is severe, you need to look for second other etiology. And systemic vasoconstriction, which also causes systemic hypertension, and stimulation of erythropoiesis, which leads to secondary polycythemia. By having frequent arousals, your cerebral dysfunction can start in your life, and loss of deep sleep fragmentation can be seen, and excessive motor activity will be seen, which leads to restlessness in the sleep, and these cause excessive daytime daytime sleepiness, intellectual deterioration, personality changes, and behavioral disorders. So this is another graphic which you fine. Okay. So if you are not treating sleep apnea, the mortality will be higher, especially in the age men 30 to 50, and not in patients over the age of 70. Moderate to severe sleep apnea have higher mortality, cardiovascular complications, and sudden death in morning hours awakening. So, untreated sleep apnea, which this slide shows mostly in the cardiac etiologies. Again, similar. So it's very important for us medico-legally. You need to be careful. You need to advise them not to drive when you're suspecting a sleep apnea. Drivers with a mild sleep apnea, they're high risk 3 times. If it is moderate to severe sleep apnea, they're at high risk for seven times. of having motor vehicle accidents. Truck drivers, there is a protocol in each and every state in the US. You need to report to the Department of Transportation. So you need to check their symptoms and regular visits to the office. They are using CPAP or not. How do you evaluate? There are common, we need to exam. Physical exam is key thing, weight, nasal obstructions, the oropharyngeal examination, neck circumference. So nasal problems. We check for Mullen-Body score. The higher the score, the chances of having sleep apnea is higher. And you need to do some MRI, CT scans to evaluate your cephalometrics and thyroid function need to check. And low testosterone syndrome is also can present as a sleep apnea. Basically showing the anatomical obstruction here. That's during this apnea event, and MRI showing significant narrowing of the aperture. The evaluation is done with the sleepiness test, which we commonly do in the office. Is the first one is Epworth sleep score and stop bang also. And we don't screen with nocturnal oximetry, but it's not a reliable screening because it can be very fluctuating numbers we can see, and we can do MSLT or MWT. This is the score, Epworth score. There are 8 questions you need to ask and score them, their severity of sleepiness. If the total score can be 24, the higher the score, like range between 8 to 23 correlates with the probability of having sleep apnea is higher. Scores below 8 is least probability. There is a different study showing what are the range of sleep apnea with the range of Epworth sleepiness score leads to different categories of sleep disorders. Stop bang is another screening model. Snoring, tired, observed, apneas, blood pressure, like hypertension, BMI higher than 35, age, neck circumference. If any one of these more than 3S, if you come with the answer 3S, that means the patient's chance of having sleep apnea is higher. Oximetry, you can see intermittent desaturations, and it correlates with the heart rate increasing, and most likely these are the REM sleep phases, which is common. Having sleep apnea and incidence is higher in the REM sleep. How do you diagnose? By doing polysomnogram, PSG. Technology attended is the standard, gold standard. Night-to-night variability can be seen, and false negatives around 15%. And we also do unattended sleep studies. These are the features we come across. This is how it looks, the hypnogram after you finish the whole night sleep study. And this is for 30-minute epoch. And night-to-night variability, the reasons are there, and how, apneas and hypopneas. Portable monitor, which is a simple way of doing. There's a nasal thermistor basically seeing the flow, and this is showing the respiratory movements with the chest and abdomen, and pulse oximetry. The 3 things are essential. Skip the question. Portable monitoring, which is commonly done in India, but there are a lot of things you need to look for. Sometimes it may not give you right answer, even though diagnosis may be sleep apnea. Sometimes it can be overdiagnosed. You need to be careful. Portable monitor study represent like this, and same as the thing, but basically how to evaluate the patient with sleep apnea. You can, based on the symptoms, which route, you can review, but I'm going to give the slides. Indications for unattended portable monitoring. These are the ones actually we do. Home study is done only when you have a high pretest probability, and patients who cannot have PSG due to immobility and safety assess the response to non-PAP treatments and not for screening, and asymptomatic patients, no comorbid medical conditions, then you can do it at home. But rest of the patients, we have to do it in-house to evaluate other etiologies related to the sleep. So, portable. Yeah. So, treatment. This is basically when the patient is symptomatic. If the sleep apnea is mild, you have to treat. If the patient is asymptomatic, you can do observation with conservative treatment, weight loss, positional treatment, And if there's asymptomatic, mild, still some questions with significant other comorbid conditions, I would look at other things, that's the number of desaturation events and sleep apnea events. And if it is moderate, you need to treat in every patient, symptomatic or not symptomatic, and if it's severe, same thing. The controversial area is this mild form with asymptomatic. So we also do conservative treatment, which is avoiding the alcohol, especially 4 or 6 hours before the sleep. Benzos needs to be avoided. Opiates, muscle relaxants, avoiding smoking, which can cut down your upper airway inflammation, and the soft tissue swelling can go down, and number of events can go down. Sleep hygiene, avoiding sleep deprivation. Safety counseling. Every patient needs to be counseled towards driving, which can cause significant hazardous issues on the road to the patient and the community. Physical positional therapy, which you can recommend them to put something on the back so that they don't fall back on the sleep. Sleep on the back. And there are some gadgets available. I'll show you the picture. And oxygen supplementation is not a primary treatment, but may be considered as an adjunct for the CPAP. This is the positional treatment. Medical treatments, dietary weight loss, and bariatric surgery may be adjunctive to the treatment of obese patients. Rarely cures the sleep apnea. 10% weight reduction, I told you, 26% reduction in AHI. Medical treatment sometimes can be used nasal steroids to cut down the nasal obstructive process. Medications only used in people who are already using CPAP with persistent symptoms, and CPAP. So this is the treatment of choice. The higher the CPAP is needed for supine position and REM sleep. That higher meaning that the pressure support from 5 to 20, the higher the number when you see the people and they're lying flat, and when they're going through the phase called REM sleep. And the acceptance and adherence are the major problems. Documentation of the adequate objective adherence is very essential. So we need to assess face-to-face evaluation. AHF more than 15 needs to treat, and I mentioned more than 5 with other comorbid conditions. So there are a lot of CPAPs available. There's significant improvement, and latest generation CPAPs are very comfortable. You see, the nasal pillows, which are not that discomfort to the patient. This is called full mask, nasal pillows, nasal mask. So this is called nasal pillows with some oral appliance to protect the mouth appropriately so that they don't leak much, and different other things. And these days, this is not commonly used. That way, it provides some comfort level sleeping on any side. Different interfaces available, which are the mask. So we need to do a face-to-face evaluation at around 90 days of initiation of treatment to make sure they are compliant and they are adherent, so that we need to document for their symptom improvement and assess the relief of symptoms and any other side effects related to the machine or mask. These are the CMS guidelines which needs to be followed here also. I'm not sure if there are any guidelines available here. And continuous use of CPAP for a period of 1 month for 30 days in the first 90 days. More than 4 hours of use per night. 70% of the nights should be used, and face-to-face evaluation. This the same thing. Okay. And people who are their adherence is good if they are more sleepy before starting the treatment. If their AHI is higher, they are more adherent. Greater perception of the benefit from the machine, or good early adherence makes you feel more compliant with the machine. Worse if they are referred by their wives or husbands, not sleepy, even with the severe sleep apnea, some people may not, and high nasal resistance, and poor early adherence itself make them poor non-compliant. And levels of either, what is the level of pressure is not going to make much difference, and the technology of the machine also should not make much difference. So, reduced adherence, there are other factors I'm showing here, and we need to keep on educating every time that they come. Avoidance of medications. The compliance report shows typically like here, how many hours they're using, how many days they're using, what is the residual sleep apnea. which needs to be checked at every visit. And what are the other side effects? Every time you need to ask about air leaks, skin breakdown, mouth leaks, or claustrophobia, and unintentional mask removal, pressure intolerance, aerophagia, bloating sensations, congestion or obstruction, epistaxis, and rhinorrhea. So supplemental use of oxygen during the CPAP. When they're using CPAP, the oxygen, roommate oxygens are dropping less than 88%, they need to be supplemented. When the absence of respiratory events. Goal oxygen saturation should be between 88 to 94%. And it needs to be carried wherever you go. There are some temporary microvalves available. It's called Provent microvalve, but it's only for temporary purposes. And it helps to prevent the leak. And basically, it keeps your airway open, so you don't lose you don't cause collapse of the airway. And oral appliances are available, which we recommend for the people with mild sleep apnea or intolerant patients, and also primary snoring, not indicated for severe sleep apnea, and it causes a lot of other side effects. Tongue retaining or stabilizing devices can be used, mandibular advancing devices can be used, and mandibular repositioning devices. It opens up the airway to pass the air completely. Oral appliance compliance is not good. It varies from 57 to 88%, but if the severe sleep apnea is even worse. Side effects, again, a lot of problems, pains, TMJs, salivation. Surgical treatments are available. Ultimate treatment used to be, when I was in medical school, only tracheostomy. And selectively, we can improve if you do some nasal surgeries, nasal reconstruction, uvulopalatopharyngoplasty, genioglossus advancement, IID advancements, and radiofrequency ablation of the tongue to reduce the size. This is what the things they do. When it corrects, it helps to resolve the sleep apnea. This is mainly for the kids, uvulopalatopharyngoplasty, and a lot of other complications related to that also. And even if you do the mandibular maxillary advancements, the efficacy is reducing the AHI less than 20 only around 86%, and less than 5 is around only 43%. This is the graphic representation of various surgeries. When they start gaining weight, we need to repeat sleep studies sometimes to see how they're doing in terms of either managing, also whether to stop or decrease the pressure or increase the pressure. When they have ongoing symptoms of hyperstimulants, despite of using good compliance with CPAP, we need to evaluate and also start some medications, mainly the Provigil or modafinil. So those are the ones. I think I'll stop here, but I have a few more slides mainly related to other sleep disorders, but I think I'll stop there. Thank you.
Thank you so much. The nice talk.
Thank you.
Thank you all the faculty and the delegates. Now let us have a lunch break and we will reassemble here after 30 minutes.